Good afternoon, one and all. So, on behalf of HOD and faculty members, it's my great pleasure to welcome Mr. Venkat. He is our esteemed alumnus of BPT 2000 batch. He has completed his post-graduation in Neurological Physiotherapy in the year 2007 from UK. So, he is presently, he is managing, he is a director and clinical lead physiotherapist in his own setup facility, Kingsnorth Physiotherapy Practice, since the year 2008. So his expertise is in the neurological physiotherapy rehabilitation. Presently, he is supporting patients admitted in COVID wards, and his area of proficiency relates to neurosurgery, neuro-oncology, and neurological rehabilitation. Mr. Venkat, it's our great pleasure in welcoming you for this global alumni webinar series. So we are looking forward to your session on patient interview skills. So this is this is one area which has not been explored much, and people talk less. As professionals, we talk less about the patient interview skills. So we are more concentrated on the clinical skills and competencies. So we neglect the soft skills. So yet the patient interview the skills are very much important in the field of rehabilitation. So here we have Mr. Venkat, who will be talking about patient interview skills and the framework of history taking in neurological physiotherapy assessment. Yeah, just before handing over to Mr. Venkat, just general instructions to the participants. As a disclaimer, the video is being recorded. Request you all to mute yourself and disable the video to enable bandwidth and avoid background noises. So you can post questions as and when it comes to your mind. You can post questions in the chat section, and the questions will be clarified at the end of the session. So without wasting much time, so I welcome again Mr. Venkat to go ahead with the session.
Thanks. Thank you. Thank you very much. Hello, everyone. Thank you for MCHP for giving me this opportunity. And thank you, Arunmaya sir, Selvam sir, for enabling this session. About me, I just wanted to give a little brief introduction. Absolutely, I'm from the Millennium batch, and I've completed my BPT in 2005. I moved to UK in 2006 and completed my master's in Neuro from Sheffield Hallam University. So from there onwards, I have work experience from since 2008 onwards in the National Health Services. Although I've moved to the private sector, I'm simultaneously working at different NHS hospitals even now. But my major workload is looking after my private patients. And I would like to move on to the challenges now when I came to UK, where I had a big culture shock for a start. And it was one of the issue was the communication and trying to relay the knowledge you have it was very difficult. So I have always felt that somebody could have given me a little bit more how we deal with patients in a completely different environment. So and also like I felt it is important to understand how people live here. So it's quite it's a steep learning curve, but it would be nicer if we have a little bit more information. So in that context, that is one of the reasons why I wanted to focus on this instead of jumping straight into the neuro skills. Because people skills and soft skills are always much more important, especially when you wanted an opportunity to show your real metal. Other things I would like to take through is, in this session, I would be talking more about challenges as a physio, especially during the consultation phase. So I've divided into like more like an introductory phase, as well as sorry, yes.
Yeah, sorry for the interruption. So
no
people would love to see you. If you can enable your video.
Okay.
Yeah.
So hello everyone again. So having control over my consultation, so that is one of the thing, and the second is my experience from the patient. You know, I've always had a lot of learning, but I was struggling to structure it well. So those two areas where I'm planning to cover in this session. So let's move on to the slides without wasting much of time. So this is my slide, which I've already covered the introduction, and then so this is where everything started, let's say. So as a healthcare professional, we always get drummed into our ears about how we should be listening the patient and how we have to understand their problems. But when we go to the real consultation, I found it was very difficult to stop them sometimes and to take control over the conversation. So that is a big conflict for me. So that is a challenge in my experience. So to overcome that challenge, I thought I have to break it down to what exactly is causing those challenges. So in a consultation, every time, always, most of us are time limited, and we have an agenda. The patient has an agenda. We are under pressure to get some differential diagnosis, or sometimes it is. It's also another softer skills that or your ethical thinking, which would be affected, like how should I connect with this patient in this time, and how could I pinpoint what I would like to achieve from this consultation. So these all are the dimensions I felt they are the ones which are stopping me from, or maybe which helped me to rethink how I am actually doing a consultation. Especially as a junior physio, I struggled quite a lot to understand where to stop these patients, because I could almost listen to their whole life story by the end. So moving on, but let's look at it in a slightly different way. So the patient came to me with some symptoms. So then my expertise is my bookish knowledge. So I have lots of thoughts around his conditions, and there are so many signs and symptoms. You have some investigations. As a physio, we have a bit of luxury to have a few investigations beforehand, and we have knowledge about some ideas of how we should manage this patient with this kind of treatment procedure, or whether so those kind of expectations we have, and you wanted to give them, with all good intentions, a cure. And this patient would always come up with other expectations where their agenda is around their idea, their concerns. They might have had some other experiences, maybe good or bad sometimes, and they have their feelings, they have their own background, where they come from. They might have, sometimes, occasionally, in some places, you might even find people have an agenda for claiming something, maybe, or something slightly different than what exactly they wanted to resolve. Excuse me. So this is all quite normal in different countries. I mean, when they don't pay, sometimes they might find they might have something else, but it's not. It's a completely different kettle of fish. It's not about saying one system is good or other system is not good. It's about how we should be prepared and be aware of all these dynamic dimensions in the treatment. So how long should we allow the patient to speak? I personally found, if we, not just me, but even the books as an evidence, the consultation would be good if we allow first the patient to speak for 60 seconds. And in that 60 seconds, we call it as a golden minute. So I have a video of for me to discuss about this golden minute, but unfortunately I don't think people are able to hear this even if I play. I can give it a try, just let me know. Selvam sir, if you could actually hear this. Video is playing. Can anyone hear anything? Hello?
No.
No, you can't. Okay, so let's do a little role play. So if anyone is able to come in as a patient and start explaining their symptoms, then we'll start listening and see if we can actually mimic this. Any volunteers?
Yeah, I request the participants to volunteer. Anyone of the participant?
Yeah,
Yes,
hi,
sir.
sir. Oh.
Yeah. Hello. Hello.
Hi, Venkat. It's Giridhar here.
Hi, Giridhar.
Hi. I can be a patient if that's useful, or.
I mean, somebody else came in first. Shall we give them a chance?
Yeah. Absolutely.
Yeah. Hello. Hello. Sorry, who else? Whoever came, whoever started speaking, could you please unmute your microphone and participate, please? Hello.
Yeah. So someone pitched in.
Yeah,
so
that's
please
okay.
go ahead, unmute yourself, or you can just raise your hand to volunteer. Already we are seeing Giridhar has raised his hand. So someone else started. Okay, I think without wasting time, I think Giridhar only can volunteer.
Hi, Giri.
Yeah, hi.
Hi. Okay. So, start being a patient. So you are in my consultation room. So you're walking in. So and I've taken your I've checked your identification. Hello, hi Giridhar. How are you today?
I'm good, thank you. I'm good. I'm really good, thank you.
How can I help you?
I can. I'm really struggling with dizziness. Sometimes if I bend down to pick up anything, if I kind of from lying to sitting, sometimes where I feel that I need to wait for a few seconds before I could stand up again. Sometimes even coming down the stairs, going up the stairs as well, I feel that I have to hold on to the banister or the sidebar to support myself.
Yeah.
I mean, it all started quite a few months ago. I thought I might have probably, because I had some insulin dependency, kind of diabetes as well, so I thought it might be due to that. But I didn't realize at that time, I didn't pay much attention because I thought it'll go away after eating a biscuit or a chocolate to support myself. But of late, in the past few weeks, the dizziness is much more prominent. In a way, it's starting to affect my daily tasks, my daily activities. That could be driving. Sometimes even in the shower, sometimes I feel that I would I would have to hold on to the wall to support myself when I'm washing my hair. So I'm just worried about it because I need to keep working to keep up my livelihood. So I thought it could help me with that because I've heard good things about your consultation. So I'm looking forward to see whether I can get a cure for that.
Sure. How long did you have this dizziness, Giri?
It started ever since I had been diagnosed with type 2 diabetes.
Okay, how long ago was it?
About 2 years ago.
Okay, so when did you have an episode where it is really bad, or is it continuous? How do you feel that is it still there? Do you have it now?
Yeah, I still have. I have it. I have it now, but it all started 2 years ago, as I said. But it was quite intermittent. It wasn't bothering me doing my work.
Yeah.
But of late, in the past, at least in the past couple of weeks.
What do you do as a job, as an occupation? Like when you said it bothers you at work.
I'm a delivery truck kind of delivery driver for a big transport company. So driving is my livelihood. So I need to keep up that to support my family and myself.
Okay, brilliant. Thank you, Giri, for doing that bit. So if we move to the next slide, like we have. So we have had, for example, we had a little. So we have a small consultation we did just now. So we can go on, but I think what I'm planning is to kind of just focus on the observation of this. Sorry, excuse me. Let me just get this back. Oh. Okay. Okay, so what we have to, there are core skills, clinical skills, which we have to, which would enable us to take the consultation. So when I try to be as professional as possible. So obviously we are aware that there is a conversation going ahead, so when Giri has given his details, I've left exactly a minute, which normally it still seems a bit longer for many of us, but it's good to have that minute in the beginning, because it gives us a lot of information about if we like how is the pattern. Maybe you can get a bit more information about whether it is like he's also mentioned about the diabetes he was having, and he mentioned that the main thing that is bothering is his livelihood. He couldn't continue with his job. So there are n number of things that are contributing to his problem. It's not just the dizziness, but dizziness is a core problem. So we are trying to get as much information around that presenting problem within this minute, but we are allowing that patient and also acknowledging with our with our body language. Sometimes we use signs, or maybe we could just make sounds, and so by various methods we can help them understand that we are listening to them. And within that after that 60 seconds, we are able to, if you observe, when he talked about I have opened up with some questions which are more open-ended questions, more to within the dizziness framework, but maybe I wanted a little bit extra information, so I had to open up from that perspective. So this is what I do with all of my patients. So when they come, I have a paper in front of me where they have that time for them to give me all the symptoms. So I tend to get all the information in that 60 seconds so that I can use that crucial information to have a picture before, and then I can I can start driving the conversation, because sometimes it may appear that we are a little bit rude when it comes to breaking the conversation, especially in a culture like England. They do mind if we stop them in between, but it is once the consultation is finished, it will all make sense. So it's always important to be brave to take the driver's seat when it is necessary, and try to build the whole picture. And I would recommend have this format in front of you to ask all that are relevant, but we'll go into the detail afterwards. So you know, like as I said earlier, so we have used active listening techniques, we have used open-ended questions, we have used closed questions, which are like when he mentioned about particularly about dizziness, he did say he was suffering, but he did not give me since when. So when he said it was from start of the diabetes, so it may be start of diabetes, but already my mind is telling me it may not be the cause, because the diabetes is a long-standing problem, and it may have been identified over the time. But it could, but I may be wrong. I'm still so this is how you almost start putting your thinking hat on even whilst you're taking these skills. So this is how I manage the first challenge. The second one is history taking. So history taking, we always that my experience is we try to talk to the patient, build some pattern with one patient. But if we have yes, it is all about gathering information. Yes, it is. Sometimes we may think, what is a big deal about this? But if you really want to learn from this patient, I found in my practice it's always good to have a proper structure, because with that structure you carry the learning from that patient to the next patient. So you'll start developing the expertise of identifying some patterns, and you will start exploring more options with different patients. So it's I found it was very useful. The next one is I'm trying to take you into more the neurophysiotherapy world, because that is my core skill. So let's say I have a patient and the patient has come with a balance problem. So always the first thing I would see as I always feel to start big and to boil it down is a good method to get to the problem of the patient. So it's like trying to unpick the situation and try to find out how various problems, but boiling it down to the core issues. So, for example, what I know superficially is this patient has come with a balance system. Second step I would think of is this balance system, is this a balance problem as a neurological problem, or is it a non-neurological issue? You have many examples that you can quote. Sometimes, you may have balance issues, even if they have MSK issues. So, but I'm not going to go deep into those. And then again, when you said neurological issues, you're talking about brain and the spine. So did they have any history to support it? Is this so you are almost asking questions to yourself from that time onwards, and then you're thinking about vestibular, or is it a non-vestibular problem? Because as you're aware, most of you, the vestibular system is mainly focused in the vestibule in the ear, and the other is basically the central system, where we try to do particular specific tests to make sure that we are separating those two, because the treatment for each of it is different. But I won't go into the details now. I'll let you read. And then we are going down, thinking about, is this a central or peripheral? I know some people might already think, okay, people are not peripheral. Yes, it is peripheral, but the vestibular symptoms are very overlapping. So it's good to go to the next question of asking yourself again to do more central tests as well. So if we can get biased, being a neurophysio, we can get a bit too biased about having a eureka moment and then just jump into treatment even before we take the steps, appropriate steps. So when it becomes central or peripheral, then you look at more tests, more investigations available, but already by this time you're thinking, and then you go down to examination side of the things, where we do the further investigation, looking at any MRI or any clinical investigation. So this is more your you're doing your examination, plus you're combining with the overlapping them with the clinical support you have, or then you think about, are there any red flags, anything that you should not be giving rehab to them, or yellow flags which you need to wait for some time before you need medical intervention before they get to the next level. And then think about the differential diagnosis. From there onwards, you can start having a list of differential diagnosis from that time onwards. Then you can, when you feel, if it is appropriate, you get to send a referral to the specialist. But if you feel that it is necessary, that the rehabilitation is required, then think about the time, how much time you wanted to give them as a session, also, or as a pack, or the time, the scale, the duration, maybe like, does it take few weeks, does it take few months, or is this a long-standing problem? So about the time. And acceptance. This patient is like maybe like 95-year-old, which is fine, and they may be very fit. So yes, this person is fine for me. But this other patient is probably 60-year-old, many number of issues, and they probably have a acute kidney failure and probably something else, which maybe he wouldn't be pleased if we try to put him in different positions and try some exercises. So those sorts of things. And then think about the skill set you have. You know, we always get carried away when we see a new patient. We think, oh, this is something which I wanted to learn, so let me take this over, which is good, but is it good for the patient? Think about it. And then think about asking for some help. Don't be brave to ask for some help if you feel that there is a need, and the expertise and asking her for help is completely different. So I always felt, you know, when you become an expert, you don't learn, but it is completely untrue. Observing your staff around you, like, do you have enough number of people to do this, to perform this rehab? You need to look at the safety side of the things. Is this patient is going to fall? If we don't have enough number of it, or even yourself, look at yourself and think, am I safe to perform this? Will I on my own? So that's the first question, and then go to the next one about the patient safety, and look at the skill set the other person have. Is this person help you have? Do you need to be a good leader to lead this therapy, or do you need it to be just you know, something, a small instructions would help because the person who is helping you has enough knowledge? So those sorts of things. And going down to the history taking framework. Now we have just talked about what we can think, but that's only a substance of what we are going to think in a neurological physiotherapy setup. But this is about a history taking framework that which will enable us to put things in the right place, because next time when we go and see, or next time somebody else wants to come and see that patient's history, they need to understand, they need to be able to deliver the same level of quality for these for these patients. So for that, we need to, this is what will enable us to have a very good clinical reasoning. That's what my experience to face the challenge of understanding the patient well and carrying this experience to the next patient. So this is just checking the personal details. I will explain you in the later slides. So initially we check the personal details, history of presenting illness, and then we go to the past medical history, family history, we take down to their lifestyle, and medical and surgical history. So these are 6 subheadings. Then you can play around with these as you would like. So this one, again, this doesn't work. So what I can do is I'll just tell you what is it. So I will, so it's where it's about, it's how do we introduce ourselves to the patient and how do we reassure? Because when we see the patient, it's the start of the, you are a stranger to the patient. So you wanted to make sure that they are happy to share information with you. So you could start off your session maybe, hello, Mr. Smith, good morning. How are you today? So he might tell you something, and then you can go to, I'm here, I'm your physiotherapist. My name is Venkat, and I would like to reassure you that your whatever discussion we are doing in this session is completely private and confidential. I'll only discuss anything that is required to the very appropriate people. So please feel free to talk to me about your medical or anything that is bothering you today. So you're just setting the scene by telling him, and you're just gaining some trust by explaining him that you're going to keep this confidential. So questions, we are asking the questions. It is good to get used to some questions because we are human, so we get, it's difficult to sometimes talk to other humans, but it is true. So it's better we have a question in our mind, which could be, this is not an exhaustive list, it's only an example. So what brought you today to the hospital? Or could you tell me what happened? So those sorts of things will open up some conversation. And could you, if you feel that they are drifting away from the conversation, you could just say, can you please describe me about your symptoms? So they might have described you some symptoms. So some of the symptoms would be episodic, some of the symptoms are continuous, sometimes they have a pattern. So you know what type of symptoms. So if they are episodic, it's good to remember that you need to that I felt like this helped me to remember this when we are having a conversation, like asking for the onset. So when did it start? That's the questions I was asking Giri. I would have progressed to, like, intensity and all these and further to the next stage. So basically onset, which means like when did it start, how did it start, and duration, how long. It's not about how long. You already got the answer of when did you start, about the duration, about how long he has the problem. This is about how long the symptom stays. It may be an hour or 2 hours, or whether is it a day or things like that. So intensity. So how, again, this is more about how bad the patient gets with this symptom. Do they have to just be confined to the bed, or can they do their a small? Are they confined to the home, or can they perform small work in inside the house? So what is affecting? In Giri's case, he was explaining that his work is affected. So he seems to be doing okay within the house, because he was also telling me that he was able to do doing tasks like climbing, and very likely that he'll be having shower, or he'll having, all these sorts of things, because he didn't say that he's taking help. So we don't have to pose an extra question for that, as long as we are sure of what we are asking. So then progression. So how does it progress? Like when he gets the symptom, how does it change? Or whether, and the aggravating factors. So are there any particular symptoms that are making things worse? Are there any particular things that the patient does that are making symptoms worse or relieving? Are there any particular things that a patient is able to do that are relieving their symptoms? So we are getting some information, more specific information. So then we are still in the presenting illness. So we are saying, so the patient said pain, but pain is slightly different from having a symptom, or is an episodic symptom, because pain needs a little bit more elaboration in a neuro world, because there are different types of pains, and in neuro there are more pains. So you could, which is surprising, but it is like I see a lot of pains along with the other problems. So again, you ask about the stop question. So I remember it as a Socrates. This is not my invention. There are people who use this. Socrates is like on the site, which onset, character, is it radiating? So you're looking at the associated symptoms. That's the extra bit. So is there anything else that is coming on when the patient is having pain? It's as simple as that. So time and duration, again, you're saying how long it's going to stay, and all these questions. And exacerbation, which is about, again, aggravating factors and relieving factors, and severity. So then the current differential diagnosis, we are starting to think now. So that's why there is a thinking man over there. So where there is a thinking hat, but it's not nice to look at. So next one is specific medical history. So we are looking at other problems, comorbidities, existing comorbidities, looking at hypertension, diabetes, blood clots, cardiac issues. These all can contribute to their symptoms. And sometimes they can be red signs, so they might just give us more red flags, which we probably wouldn't really, we are not supposed to do the rehab unless they get that resolved. So then we can probably start thinking about more closed-ended questions here. So this is another prompt where you can start asking more closed-ended questions. For this one, we are talking about the personal history now. So we can think about the medications, but remember to ask both prescribed and non-prescribed, because many patients use drugs or medications from a pharmacist, or they might just it could be just they buy themselves. Sometimes they can just buy from a different place, or a non like maybe something like a Ayurvedic medication, or a different one which we don't probably necessarily have a lot of knowledge about it, but they are effective, so they might just interact with the medications and cause the problem. So always think about not just about that medication, what it does, but also think about what it does when you have another medication along with it. And also alcohol. Alcohol is a medication. So if you combine with it some of the blood thinner medications, it can be, the alcohol becomes more effective, but it's also not good for the body. But there you go. So there are like smoking. So this is the medication. So it's not just one question and leaving it there. You need to. I found it is important to dwell a bit deeper about why we are taking those medications. Why are we asking for the list? And the allergies, family history. Like there are so many diseases that are associated with family history. And then traveling abroad. Sometimes people pick up different like maybe some viral infection or something from a different place when they went, and they might end up with having some GBS symptoms. So it's important to know that where they have traveled sometimes. But it's an optional, I would say, if you really feel it isn't, but probably just get used to it, and then you can have some options. Occupation. So like I was asking a person, like for example, Giri's thing we have talked about, where we discussed, he was saying he was a driver. So maybe his dizziness, maybe like he might have had an accident recently. So I might go into those details. So it may be possible that he didn't want to talk about, because he's psychologically he didn't want to discuss about it. So but there may be head injury underlying, which I didn't really discuss. So things like that. So social, it's about cultural issues, sometimes, language, sometimes, there are some soft issues around this you could pick up. And sometimes there are some neurological problems which are more associated with particular race, and even some things like Parkinson's, they affect some Arabic people in a different way in comparison to from a different race. So there are anomalies, so worth bearing in mind. And anything else you would like to talk about? So those sorts of the questions you could ask. So how would you differentiate or self-criticize yourself, whether you are a novice or an expertise? So there is no like any scale to say, oh, this person is expertise, or any scoring, but it is about how you take your history and how you use the information, which makes you more novice or expertise. So novice physiotherapist, generally, this is not anything out of a magic hat. This is from an evidence-based study. Mr. Stephen May is my teacher, as well as studied, like Giri studied in the Sheffield Hallam University, so he has got the same teacher. So he's done a study where, and there were other previous studies where generally novice therapists used hypothetic co-deductive model, which is a bit mouthful, but what it means is you take a hypothesis and use that to make another hypothesis, and then make another hypothesis. So it doesn't have a lot of evidence behind it. It's for us to criticize ourselves. It's just to kind of think about, how we are practicing. Are we actually making every decision in a meaningful and a clinical pattern? Is there a clinical reasoning behind it? So if you look at your assessment, is it coming out as whatever you started, you have a solution at the end, which is which is more meaningful for the patient and gives you an outcome. So that will improve our clinical reasoning. And next one, let's go to the summary. So history taking is crucial, as we have already discussed. There is a clinical reasoning process behind this, and it's good to use appropriate open-ended questions, and use of closed-ended questions is highly recommended when we are having a direct conversation, or we are having some conversation to drive it to particular things. And it's important to have a combination of book knowledge and have a knowledge of patients, and develop that clinical pattern to recognize. So that is my learning. There is a question type, but before that, a question for you. So let's look at a little clinical scenario. Okay, so there is a 78-year-old male with a history of atrial fibrillation, hypertension, diabetes, and coronary artery disease is referred for evaluation of dizziness. Okay. And then the patient had recurrent episodes of dizziness and falls. Most of these falls happened when he was bending over, turning around, or climbing stairs. So there are falls with this dizziness. So we have some more history. During his initial consultation visit and follow-ups with the general practitioner, there was a concern of TIA. An MRI of brain was obtained, which showed non-specific white matter lesions. And there is echocardiogram, showed left ventricular hypertrophy and right atrial dilation. And they have revealed atrial fibrillation in the ECG as well. And you can see there is a ultrasound that showed carotid artery narrowing, which is 50 to 59%. And they ruled out TIA, which is transient ischemic attack, which is similar to stroke, but in a smaller way. So vascular surgeon did not think that this dizziness was due to the carotid disease and referred him to neurologist. And the neurologist further referred to the neurophysiotherapist. So this is what normally happens in our lifestyle, as a neurophysio, because this is a real case. And then when we go to the next level, so I'm going to give you some answers, but I would like you to, I'll try. There is something called the Mentimeter. You can actually log on to that and use a code and just write down which one you think is the most possible cause. So I might have to share that. So let me go out and see if I can share that. So this is, sorry.
Yeah, is that a place where they can enter the right answer?
Yes, they can just use this code and they can just enter the...
I think that will be little lengthy process. Rather, they can write in the chat. They can write in the chat box here, because I think this is the only question.
Fab. Yeah.
And they can write. They can just type the right option here in the chat box.
Absolutely. Yeah.
Yeah. The participants. If you can just put up the question.
Yeah.
So based on the clinical scenario, you can just identify the condition of the patient. And you can type in your responses in the chat box. Yeah, there are 5 options: carotid disease, vertebral artery disease, cardiac arrhythmia, orthostatic hypotension, and vestibular dysfunction. Please type in your responses in the chat box.
Sir, I can't get access to the chat box. It's disabled. I don't know what's the reason.
Is it?
Yeah. It says the chat is in channel meetings is only available to team members.
Just a minute. There is. No, actually, we couldn't see that option here. Okay, anyway, so the participants can just unmute and they can just speak out.
Answer B, sir.
Yeah. I think I see Mr. Jayabalan Prakash. He is online. Please proceed.
Sure. Hello, sir.
You can introduce yourself.
I am J. Prakash, working as a professor in Kingsnorth College of Physiotherapy, Coimbatore, sir.
Hello, sir.
Tamil Nadu.
Hello, sir. Nice to meet you.
Good evening, sir.
Good evening.
The second answer B, vertebral artery disease.
Can you describe, sir? Can you describe why you thought it is a vertebral artery disease?
Because VBA symptoms, so more, how we can say it's so very important arteries. It's, if anything is going to occlusion, if even if going to do any manipulation or any physiotherapy techniques over the neck region, you should always check for VBA. Because if patients have anything is having dizziness, 5 Ds we commonly check in VBA.
Yes.
Dysarthria, diplopia, and drop attack, other thing. Maybe that's the reason I'm thinking vertebral artery is one of the causes of dizziness.
Sure, sir. Sure, sir.
Okay, before coming to the right answer, if we can have other responses, if someone agrees or disagrees with the option.
Thank you, sir.
Thank you,
sir. Thank you very much.
Yeah, is there any participants? Any other participants who wants to agree on the option or disagree with the option? Okay, there are no takers.
Okay, sir.
Yeah, you can please proceed. Yeah, you can just.
Oh, do you want me to? Yeah, go ahead.
Yeah.
Yes, sir. I mean, Professor is right, but there is it's a 50-50. So what? And then the other one, which is 50-50, is a vestibular dysfunction. So these are the so what the point of this is, if we can so this is only, I've only given only history, and there are certain things which we can, like, there are some investigations, so we may have to ask further questions on certain like on certain the maybe the differential diagnosis. If you think this is a possibility, then you go to the next level. But absolutely, vertebral artery disease is one of the queried, and then vestibular dysfunction is the second one. But this patient got diagnosed with vestibular dysfunction. It's because of the very similar grounds, but they have to do like caloric tests and other further tests to confirm it. So, but you're absolutely right, sir. So that is these are the two that came out. So you can actually see, like, carotid artery disease is not possible, which is causing the dizziness. So it's like you can bin it. So there are some, so you can start grading the options. You could say, like, if you think about the 100% chances, none of us are able to say 100%, but we would be able to go to 60-70%. So that's something you can just put in a box and think, okay, this is the maximum chance of these kind of this probably patient is suffering from this, and then you can go to the next level. So that is the whole point of this exercise. So there are some symptoms you could clearly see, the orthostatic hypotension, other things which probably very, very unlikely. So then you can just comfortably put them away. So if we start thinking about it, we won't start treating for things which we feel that are not necessary, and especially physios or autonomous practitioners. So we got to get things right and start and think about what would be the most likely cause. And in occasions, sometimes there are ENTs who couldn't diagnose, and physios managed to diagnose them and send to the right test. So this is not about what your background is or where you come from or what knowledge you have. It's about learning and learning in an effective way. So before I close my session, I just wanted to give you just a couple of take-home messages. I would just wanted to discuss about one is establishing own business, and second is about making a job application. But these are not, like, I wouldn't call myself expert, but I just wanted to give you some ideas about what I have learned over the time. So if you're planning to set up your own business, I would strongly suggest do not go blindly and set up anything. Make sure you know what your who your stakeholders are, identify them, and do your SWOT analysis for your business and make a business plan. I myself spent about 6 to 8 months to just get the business plan and work on your cash flow. So then always be prepared to review your business plan once every 6 months or in a year, whichever way it is required, and be resilient and be clear about what you wanted to achieve for that season. Maybe you could call it maybe an year or more. And then if you're applying for jobs, please be aware that job spec is very important, and it's how you sell yourself on the job spec. So please make sure you put facts and feel comfortable to modify your CV to make sure, and it's almost like if you're sending a CV without sending a non-tailor-made CV for a job, you're almost stitching a shirt which is a different size and just giving to the other person and calling it as a shirt. So that's how bad it is. So we just got to make sure if we want to get opportunities, definitely please make sure you're writing your jobs, read the job spec, make your CV for getting things ready. So that's me. Thank you for giving this opportunity. Thank you very much, sir. Thank you for your time. And please feel free to ask any questions.
Thank you so much, Mr. Venkat, for that wonderful session. So before that, I just wanted to ask the participants, if you have got any questions, please feel free to post questions to our speaker. Please unmute yourself, introduce, and then you can ask the question.
Hi, sir. It's Giridhar here.
Yeah.
Hi, Giri.
Yeah. Hi, Venkat. Thank you for the session. I mean, I took a few points from there as well in terms of history taking, and in ensuring that you need to get your facts right, and then you need to make sure you follow the pattern and the framework to get the information you need. Just taking it back a little bit, I just want to ask you, how challenging was it for you in terms of history taking that you've done in Manipal, and also when you started the job as a junior physio? How challenging was it, or what have you done to overcome those challenges?
I mean, in Manipal, obviously my book knowledge was limited, and even the patient experience, although we have started, and despite having very good teachers and excellent provisions, you can always, we are very, I mean, as a student, we are driven to get some marks. But, you know, obviously that is important for that time. So I have I've learned some skills, especially when I see some, from a non-medical profession, they struggle to even ask people about some intricate details of the problem, or, you know, they struggle to discuss problem with their own parents. So that is something which you develop as a junior. So you get the ease, I felt, and then you get the ease of testing and trialing. And then when I moved to a different place, I've first learned about the culture, and then felt that is very. It's crucial to understand how people behave and how we got to approach, especially the manners in one place is different. Like maybe an eye contact you got to have a very good eye contact, and you have to have a good open body language. because people can misunderstand how we want us quite easily, and it almost costs your business when you're elsewhere. But if we are in some places, it is acceptable to be the boss and be dictating what you have thought is right, and in some situations it's okay. But when you move to a different place, there are cultural lessons I've learned, and that I would say is the biggest challenge for me, to change myself. But everybody can reinvent themselves, so I felt definitely it's a learning curve for me. Did it answer your question, Giri?
Yes, thank you.
Yeah, thank you so much, Venkat. Just a quick thing to the participants. Because of chat box, we could not post in the chat box the link for giving the feedback. I've just projected on your screen. Hope everyone is able to see the screen.
Yeah, please do give feedback, because it is going to be really helpful
so
for
as
us.
a part of quality initiative, we would love to get the responses from you. We wanted to reflect on our webinar sessions. So this is going to be a fruitful exercise, both as organizers as well as presenters. So please take some time to submit your responses. So I think any questions from the participants? Okay, we have done. So it's so nice of you, Mr. Venkat, for having accepted our invitation and extending your support for this global alumni webinar series. So it's a quite interesting topic. So patient interview, it is a central and integral part of any clinical practice. So, it gives a lot of qualitative information. So it is not going to vanish away. So these days, there are so many algorithms coming up. Just enter the symptoms, you come up with the diagnosis. But when
it's a very dynamic process.
Yes. So when it comes to patient interview, you get to know the patient as wholesome, and you get a lot of qualitative information so that you can rationalize your clinical decision making. So it is very central, and it is not going to vanish away. This is the heart of the practice. Everyone should inculcate those skills of relating themselves to the patient for a good clinical practice and prove themselves as a successful professional. So you have brought out very well the core essence of patient interview skills. So hope I don't see participants asking question. I think should we call off the session? Yes. Any final thoughts, Mr. Venkat?
Thank you very much, sir. Thank you for the opportunity, and hope it all made sense. I mean, anybody feel free to approach us. It's our teachers in Manipal who started off giving like knowledge and interest from their experience. So they have inspired us for us to still keep practicing physiotherapy so long. So all I would say is, please do approach us if we can be of any help. We are happy to help you. And there are quite a few people, like a student from Manipal, who have come over here, and not everyone is a part of alumni, but that's it's important that we work together and share information between us. Yeah, please feel free to approach me if you have anything. If you feel that there is anything I can help you, I can always be there. Thank you.
We take immense pride in seeing that our alumni are doing well across the globe. So it's a really good feeling, and hope you all will stay connected with us and just pass on the word. So we here at Physiotherapy MCHP count you all, and just keep the word spreading and to expand the network.
Thank you, everyone.
Thank you so much. On behalf of HOD and the faculty members, I thank you once again.
Yes, bye. Thank you very much. Thank you. Bye.
Bye.
somebody attempted to call me. Hello.